just like in the brain. Now, STIR sequence is very good sequence to look for edema in the marrow, and a King sequence for bone marrow edema. So we do it very often in the spine. In a department, if if the clinical is even for, let's say, a lumbar spine, if the clinical is either trauma or infection, then you must add a STIR sequence. Another interesting point is that now we use STIR sequence to pick up plaques of demyelination also in the cord. So this is interesting because initially people used to think that on STIR sequence there is a lot of artifact in the cord. And for MS, we used to do T2 and T1s or T1 with contrast. But now we do a STIR sequence for intramedullary lesion as in plaque of demyelination. I don't think so this is important for you in the exam, but in your department, maybe you would like to include the STIR sequence for MS. Now, T1, of course, is, all of you know that on T1 fat is bright. So this sequence and the STIR sequence, these two sequences, they come in the exam so often. You know, any marrow infiltration, these are the King sequences, and even yesterday, day before yesterday, we saw them again and again. May it be infection, may it be tumor, it will be low on T1 and high on the STIR sequence. One of the key things to recognize in the spine is that the marrow will be higher signal as compared to the intervertebral disc. Now, this case is quite advanced in age. In a younger patient, the marrow will not be as fatty. You know the basics that marrow has got red component, red marrow, and fatty marrow. So it might not be all that fatty. And if you are doing a PEDS case, then it becomes very difficult. So the key formula is that the marrow should not be lower in signal intensity than the intervertebral disc. These cases have come in the exam where they will show you diffuse marrow abnormality, and if you don't know this formula, you're not going to pick up. Now, key point here is that if you see abnormal marrow, I'll show you cases later on T1, always compare it with the STIR. And by definition, please remember that STIR means fat saturation. So look at this case, look at the marrow, it has become dark. So this is what happens. Now, this sequence, you will always find it tricky. Why? Now, this is a fat saturated T1 weighted sequence. And fat saturated, everything becomes bright, much bright than you see in a T1. And similar phenomena you will also see in things like liver, etc. So you have to develop your eyes on this, that this is a pre-contrast T1 and this is a post-contrast T1. Post-contrast in spine is a tricky one, and either there will be things which are enhancing, which will tell you that this is a post-contrast, or maybe at times the examiner will tell you also. So these are the sequences, the names which I told you. Okay, candidate 1. This is T2, this is post-contrast, and this one is pre-contrast, T2, T2, T1. Over to you.
Okay, so I'm presented with selected spot images of the cervical spine in a 13-year-old male patient. And at the level of C2, C3, I can see a lesion which is causing mild cord expansion. It's high signal on T2, low signal on T1, and demonstrates enhancements. I can't see any other associated lesions. There's surrounding mild perilesional edema, and I think in this age group, my top differential will be an astrocytoma.
And what is your differential?
So in this age group, I think hemangioblastoma is also another possibility. ependyma would be unlikely in this age group and doesn't have the right characteristics. So it would be between astrocytoma and hemangioblastoma.
Right. Why did you say that ependymoma is unlikely?
So I would expect there to be hemorrhagic signal. It's more common in an older population, and you tend to get a hemorrhagic cap with it.
Right. So, okay, your general thinking is fine, but a bit of fun touch is that, my take-home point for you will be that it is good to tell the examiner your thinking, as you have just told me. But ependymoma and astrocytoma, they will always go together. You are right that in this age group, astrocytoma is more common, ependymoma in the adult population is more common. You are right that hemorrhage goes in favor of ependymoma, but the counter argument is that both of them can occur in each age group. Number one, both of them can have cystic component, and even astrocytomas as at times have got hemorrhage. Hemangioblastoma, on the other hand, is quite unique because hemangioblastoma think like brain. In the brain also, hemangioblastoma, if you see, can have classical hemangioblastoma is a cystic lesion with a very arterially enhancing nodule. And it will be so bright that on angio you will pick it up, right? So, that is classical appearance, just than what you see here. Otherwise, your differential is fine. So, astrocytoma up there, you are right. But even if you say that in the same, description, then tell the examiner that because of this, it is less likely. And please also remember ependymomas, for example. What about NF2, for example? So they can show you a case of NF2 where it will be a child, 5 years old, with ependymoma. So, and there might be something sitting upstairs in the brain. And once you pick it up and then you say that I want to see the neural axis, and you will pick up. Okay. So in Chapman, the last differential diagnosis of this chapter is important. Basically, today's session is just the last differential diagnosis of the spine chapter. This is the chapter 2. I was lucky enough to be one of the co-authors of this chapter also. So, and there are a few modifications as far as the previous edition is concerned. If you see this differential diagnosis, please remember this whole of my session today is this differential diagnosis. And many of these things have been covered in MSK, so I'm not going to cover. I am going to basically sort of concentrate in this territory and something in this territory. So if you see overall, this is Chapman 2.17, and here the three or the four headings, the main headings are extradural masses, intradural extramedullary, intradural sorry, there is I think a typo here, so apologies for that. So this is intramedullary lesions, and then lesions related to cauda equina. So the extradural masses, a key thing for the exam is that there are a few lesions which can occur anywhere, intramedullary and intradural extramedullary as well as extradural. Metastasis behave like this, lymphoma also, and sarcoidosis. Sarcoidosis is known as the greatest mimicker in neuroradiology, and it's a favorite for the examiners. So you have to please always remember sarcoidosis. So we have seen cases of diffuse marrow abnormality and it came out as sarcoidosis. I'm not expecting you to pick that up, but if you get a long case, then with other stigmata of sarcoidosis somewhere else, keep your minds open. Now, this is intradural extramedullary, And in this one, schwannoma, meningioma, neurofibroma, these are all important. Any leptomeningeal metastasis, they are very important. Other leptomeningeal processes in which again sarcoidosis and meningitis, TB meningitis, fungal meningitis, anything that is very important. And so our main curriculum today will be intramedullary mass or swelling. And if you see here, ependymoma, astrocytoma, hemangioblastoma, these are the top three differentials. Metastasis is there, lymphoma is there, ganglioglioma is rare. So from a 2B perspective, you can forget it. These things are important. Multiple myeloma, multiple sclerosis, acute disseminated encephalomyelitis, neuromyelitis optica, transverse myelitis. I will tell you today what is the difference between this and this. Cord infarction is important for the exam, and vascular malformations are important. All of these things are important. Dermoid, epidermoid have come in the exam again and again. Sarcoidosis, of course, can come. So, and we have added a new differential this time, and cases have come in the exam from this one. So these are lesions related to cauda equina, so lumbar spine level, and things like Guillain-Barré and these things, chronic inflammatory demyelinating polyneuropathy, and other. I'll show you cases from this territory. This is a repetition. I've shown you this case previously also, but it's a revision case. So over to you, candidate one.
So I'm presented with frontal and lateral radiographs of the lumbar spine in an adult patient. So on the lumbar projection, I can see posterior scalloping of the vertebral bodies. There's also some destructive change to the lamina from level L2 to L5. Having a look at the frontal view, there appears to be some lateral displacement of the pedicles. The two combined together makes me think of a intraspinal mass, which has been long-standing for a long time. The differentials for this could include things like mucopapillary ependymoma. You can also get this in things like urolactasia and NF1. I would recommend a spine MR for further characterization.
Okay, fine. Now, if you see, this is at the AP film, and this is what, if it comes in the exam, if you look carefully, look at these pedicles, this pedicle, and compare it with pedicle here, for example. Look at this pedicle, how thick it is. So these are sort of compressed laterally. So if this is the interpedicular distance, this distance is increased. And in your Chapman, there is a differential diagnosis in MSK, or in the spine, increase interpedicular distance. So this is a classical exam case. Now, if you look at the lateral, the examiner can also just begin with the lateral. Now, if you see here, there is posterior scalloping, and there is a differential diagnosis for posterior scalloping. The beauty of this case is that if you look at the pedicle here, you can see the pedicle well. Here, the pedicles are missing. Actually, why are they missing? Because they are so thin that because of radiographic factors, the X-ray beam is passing very, easily through it. So they are not projecting very well. So this is the lateral, and this is the AP. And this is again a revision case, and this is you have seen this case before also, but having said that, and this is not this one. This is a different case. I don't have an MR for this case. I got an MR of the same pathology, this one. This is T2. This is contrast enhanced. And so these are pre-contrast, and this one is post-contrast. This is a T2. Over to you.
Okay. So on the sagittal T2 weighted imaging, I can once again see posterior vertebral scalloping. There is a heterogeneous lesion within, which is demonstrating heterogeneous T2 signal. On T1, it is iso-intense to the intervertebral disc, and on post-contrast imaging, it demonstrates heterogeneous enhancements. Having a look at the axials, it's causing significant canal stenosis. And at the level of L4, L5, I expect it to be involving the cauda-equina nerves. Given this location, my top differential will be a mucopapillary ependymoma.
Mixopapillary, right?
Mixopapillary ependymoma.
This is the word, mixopapillary ependymoma. So let's see this. First of all, let's see this picture. So this is a particular type of ependymoma, which of course happens in this part of anatomy. It is a slow-growing lesion, and because it is slow-growing lesion, it will cause posterior scalloping of the vertebral bodies. And if you go back to this case and see what happened on that plain film, look at, this is one pedicle, this is second pedicle. So the tumor, because it is long-standing, it is causing scalloping here, and similarly it is causing pressure effects on the pedicles. So the pedicles will be narrowed, and the interpedicular distance will be increased. And one of the key findings is that you can see this hemosiderin, which is low in signal intensity on T2 weighted sequence. So that's the point to remember, that ependymoma, quite often they have got hemorrhage. And this hemorrhage is what we call chronic hemorrhage, which is low in signal intensity on T2 weighted sequence. Similarly, intramedullary ependymomas in the cord, as was pointed out in the beginning, that they will also have hemorrhage, very common for them to have hemorrhage. And that is a discriminator between ependymoma and astrocytoma, because in ependymoma, hemorrhage is quite common, and not so in astrocytoma, but in some cases you might see it also. So this is mixopapillary ependymoma. And this is the differential diagnosis from Leo Chapman, widened interpedicular distance, and there is another one, posterior scalloping of vertebral body, which is this is the differential diagnosis. Tumors in the spinal canal is the most common one. Yes, please. Candidate one.
Okay. So I'm presented with selected axial MR images of the brain and a coronal and a sagittal. So the first thing I note on the coronal T2 within the cervical spine is an abnormal signal in the intramedullary cord. It's quite central in position. It's high on T2 compared to grey matter and low on T1. Having a look at the brain to see if there's any other associated lesions. I can't see any parenchymal brain lesions, and the orbits and optic nerves have a normal appearance. So my differentials for this solitary intramedullary lesion would include inflammatory causes such as neuromyelitis optica. I'd also include inflammatory causes for this, things like transverse myelitis. I'd recommend dedicated spinal imaging to further characterize.
Over to you. So I've given you dedicated imaging. This is post-contrast. Okay. This is post-contrast. Post-contrast, this one. This is post-contrast.
Okay. So again, having a look at the cervical spinal canal, I can't see any other lesions. It appears to be a solitary lesion at the level of C1. There isn't any significant perilesional edema. And on the post-contrast sequence, I can see rim enhancement, which appears to be a complete ring. Having a look at the coronal and the axial images, sorry, I can't see any other abnormalities. So I think given the enhancement pattern, the top of my differential would be a demyelinating condition such as neuromyelitis optica.
Do you see the cystic component here, where I'm pointing out on this T2?
Yeah, high signal centrally. Okay, so given that it has a cystic component to it, other things to consider would be tumors such as hemangioblastomas would be in the differential.
Okay, fine, I'll take over. The point is, to show you this case is what I call edge of the film case, again, favorite in the exam, where you are being shown a MR of the brain and the pathology is either in head and neck or in this case in the cord. So you pick up something there, and when you pick up something there, then you ask for dedicated imaging. So instead of giving differential diagnosis initially, and this is what happens in the real world also, the first thing is dedicated imaging, particularly contrast is critical here. So you give contrast. Now, once you give contrast, then comes the, is it demyelination versus, let's say, a tumor? So please remember, in the real world, many a times you are not very sure. So if you see some associated finding in the brain, etc., or let's say the optic nerve, etc., then you go for demyelination. But at times, follow-up scanning and things like that will give you the answer. But having said that, demyelination, early demyelination, will not have this cystic type of component. And you can see there is a subtle maybe enhancement and there is nodularity there. So hemangioblastoma, of course, you can keep it in differential blood as we have discussed before, that classically there will be a tumor blush. I've shown you hemangioblastomas previously when we covered, phacomatoses. And that will be very, very densely or intensely enhancing. They can have cystic component at times, very, very long segment cystic component. So here, the top differential will be a tumor. And the tumor, as the first case which you saw, astrocytoma will be up there. And ependymoma less likely or unlikely because of lack of hemorrhage, as you pointed out in the previous case. Okay, over to you once again.
Okay, selected sagittal images of the cervical and thoracic spine. So I can see an abnormality in the cord where there is expansion of the cord with an intramedullary lesion. It's causing abnormal cord signal, and on the T1 weighted imaging, I can see some high foci within. On the STIR image, I can see heterogeneous signal and an abnormality extending up to these craniocervical junction. It's quite a long segment pathology. I think given the high T1 signal and the distribution of an intramedullary mass, my top differential will be in ependymoma.
Very good. So in this particular case, if you see it's a long segment lesion, by the way, astrocytomas at times can be even longer, and to get a 4 segment long astrocytoma is quite usual. So that is not a discriminator. And in this case, basically, if you see the tumor itself, it is enhancing, but the key finding for the exam is hemosiderin. And hemosiderin, we call it a cap sign. Cap can be at the edge, lower edge, it can be at the upper edge. And hemosiderin is low signal on T2 weighted sequence. There is another concept which you have to remember, that there can be a cystic component of the tumor, and the tumors can also be associated with a serings like this. So here we will keep ependymoma as the number one because of the features which we have just pointed out. This is a revision case which we have covered in the in our brain module. Can you please describe your findings?
Okay, so I'm presented with multiple spot MR images of the brain and cervical spine. So on the top left images, I can see high T2 signal.
These are all post-contrast,
Okay.
T2. This is T2, this is post-contrast, over to you.
So in the top images, I can see enhancing lesions at the CPA angles bilaterally, which appear to extend or appear to be expanded. On the third image in the top row, I can see a lesion in the left temporal lobe, and I can see a suprasellar lesion. Having a look at the images of the orbits on the bottom right image, I can see asymmetry between the globes, and the left optic nerve, comparing the left and right optic nerve, the right optic nerve appears to be enlarged and expanded. Looking at the cervical spine on the two-weighted image, I can see multiple lesions which are causing cord expansion and have high signal within, as well as heterogeneous low signal. I think the constellation of findings are bilateral schwannomas and optic nerve meningioma and spinal ependymoma, as well as intracranial ependymomas. The most likely diagnosis in this case would be NF2.
Right. So this case is a NF2 case, and in this case we can see bilateral caustic schwannoma, we can see multiple meningiomas. This is a suprasellar meningioma, and this meningioma then, because this is not a fat saturated sequence, you don't see it very well. But what is happening is that from here the tumor is going in around the optic nerve, and there was a lot of calcification also on the CT scan, which I have not shown you. But on the T2 weighted sequence, you can infer that calcification because of this low signal. And with that is this cord lesion. So we have all covered phacomatoses, and you know that once you see something in the brain, you have to ask for rest of the neural axis. So you have to ask for the spine imaging. And just as a recap, this is the definition of NF2, and this is the mnemonic: multiple inherited schwannomas, meningioma, ependymoma. So that is just for review. So this is a T2, this is a T2, this is a, what is this session? What is this section? Sorry, sequence?
T1,
What is this?
pre-contrast.
So this is a fat saturated, right?
Saturated, sorry.
So yeah, you were right, pre-contrast, but just use the word fat saturated because you know, in the spine, classically, we do fat saturated. At times for intramedullary lesion, even if you don't do a fat saturated, it doesn't matter. So this is a fat saturated. What is your diagnosis? Over to you.
So I've got a well-defined centrally placed cord lesion with minimal edema, and it drops out on fat saturation and is high on T1, so it's a fat-containing lesion. Cord lipoma?
Lipoma.
Or
Maybe a dermoid.
Yes. Yeah.
Yes is the answer.
Yes.
So please remember, lipoma will not cause anything. And dermoid can potentially cause what?
Rupture and
rupture, yeah. So irony is that it's a benign thing and it can kill a person. And if there is a ruptured dermoid, it causes chemical meningitis, and then prognosis is not very good. And so a ruptured dermoid in the cord or in the spine can present upstairs in the brain, and I've shown you cases in the past also where there is something in the CSF space on a CT scan which will be darker than CSF or a MR, and then you will ask for a cord sequence to rule out a ruptured dermoid. Having said that, how do you discriminate, radiologically speaking, between a lipoma and a dermoid? And this is a key question for the Viva.
I think this would be an extremely atypical. So it's where I've heard about it is lipoma of the kind of terminal, the phylum terminale. So it's at the end.
So please remember, if you read your Chapman, it tells you that lipomas can also be intramedullary, by the way.
Yeah.
This case is from American College of Radiology, and this is irony is that they operated it, and this is a biopsy proven lipoma. So radiologically speaking, when you see fat, look at other signal. A lipoma will suppress completely, but a dermoid, histology-wise, dermoid has got various components. There will be something other than fat inside a dermoid. So that is how you discriminate radiologically speaking, right? So this is complete fat, and so this is a lipoma. Now, because you are seeing spine here, because you know we are covering the spinal canal, it becomes a very easy case what I am showing you right now. But beware that, suppose it was a CT of the chest. And do you see something in the spinal canal?
Yes, there's so I've got sagittal CT on bone windows and soft tissue, and I've got a hyperdensity at the level of the upper T-spine, the upper thoracic spine, and that's also associated with low density within the spinal canal. On the axials, it's clearer that there's two foci of hyperdensity within the canal. Then in the second, looks to be normal cord, and then in the third image, there is low density.
So what can you do to evaluate further, just on the CT, I mean to say?
If they had, this is a contrast enhanced, isn't it? So I would look at the pre-contrast, if there was one available.
Mm-hmm.
To compare just on CT alone. Ideally, it would be great to evaluate on MR, but
can you see this density and compare with this subcutaneous density?
Yeah, it's. I was going to say overall, it's quite a low, heterogeneous looking cord lesion with potentially calcification and fat density.
Okay, so how
raising the
my
suspicion
question
of
was very basic.
germ.
How will you check the fat? Is there fat inside or not?
I could do a region of interest, like a
Here you
pinpoint
are.
region
So
of
that's a classical scenario, and you have to tackle it like this. And what is here?
It confirms my suspicion, so it's -69, so consistent with fat Hounsfield density.
But it is not completely fatty. You have already seen calcification, and you have seen, there is some soft tissue also there, right?
Yeah.
So, what comes to your mind? Conclusion?
A dermoid again.
Dermoid. This one is dermoid because there are multiple densities. So the point I am making here is FRCR exam, unusual presentation of common finding. Common, if I show you an MR of the spine, you will pick it up. But so now what you have learned, a sort of a review area that on a CT scan look inside the spinal canal. And please remember, they have shown a case of diastematomylia on a CT scan. You see, if I show you a diastematomylia on an MR, a child can pick it up. It's too easy. So they will. So that is what this exam is about: unusual presentation of a common finding. So this is the MR of the same case actually, and if you see here, just as a practice, just describe it.
So I've got a heterogeneous central cord lesion of mixed signal intensity.
Name the sequence. What is this sequence?
T2, followed by
this sequence. This one.
T1.
This one.
Pre and fat saturated pre contrast, fat saturated post contrast, and then I've got axial slices below. T1, T2.
So I've given you. Yeah. So how do you, just for practice, can you describe it?
So I've got a heterogeneous lesion that within the central spinal cord of mixed signal intensities, there is a central hypointensity both on T1 and T2 that correlates with the hyperintensity seen on CT. There is surrounding hyperintensity on T1 and T2, at which then is not as is saturated out on the fat saturated images. There is some post-contrast enhancement of the soft tissue density that is seen within the middle, and there is a fat fluidy level looking thing on the T1. Sorry, that's not very funny.
That's fine. Now, interestingly, that's fine. So this is another dermoid. Interestingly, we got a secondary opinion from tertiary neuroradiologist on this case, and some of the gurus, they think that because there is a bit of enhancement, they said that it might be a teratoma. But other people think that at times some enhancement might be seen in a dermoid, but actually most people think that this might be a teratoma. Teratoma per se is not an exam case. The point is that if you pick up a fatty thing, that's fine, because teratoma will have multiple other layers also. This is the type of scenario which will come in the exam. What do you think is happening here?
So I've got, I think that it's ruptured because there's evidence on T1 of hyperintense foci along the cord, as well as an intramedullary lesion that is consistent with a lipoma or a dermoid. So I'm concerned that it's ruptured, especially in the context of acute headache.
That's fine. So I've shown you this case before, and not this case, similar cases. Ruptured dermoid on an MR, they will show you a T1 weighted sequence with high signal in the CSF. On a CT scan, it becomes more difficult because it will be low density and the density will be lower than the CSF because and you will tell the examiner, I want to, because it might be air also. Air is also an exam case, right? So, so you do the densitometry. And in this particular case, even here, you can see the same thing. And this was another ruptured dermoid. I have not shown you a case of ruptured dermoid or a dermoid with a dermal sinus or an epidermoid with a dermal sinus. Remember, that can also happen, that this thing might be connected to something which is connecting to the skin, dermal sinus. And please remember that at times you can get abscesses and things like that secondary to that. Okay, so this is a T2 weighted sequence, T1, contrast, and we have not done a fat saturated, and this is a DWI. Over to you.
Okay, so there is an extramedullary lesion at the level of the conus, at conus level, that is exerting extrinsic compression onto the cord, pushing it anteriorly. There is some rim enhancement of this on contrast enhanced sequences. It's hyper intense on T2, ISO intense to...
Can I stop you? Yep. If you see carefully on this pre-contrast, this rim is similar to this rim. Actually, it is not enhancing. So I can do this.
Thank you. So it could be a hemosiderin kind of. And on axial.
So what do you think is happening here?
Densely, I would want to map it up with the ADC, and if there was corresponding low signal, then that would confirm restriction.
Wherever there is bone, remember the basics. When there is bone, for example, in the temporal bone, physics-wise, ADC will have a lot of noise and things like that. So if it is bright on DWI, just call it. And even in liver, it becomes a problem to check the ADC. So, so this restricts. Now, with this, what is your conclusion?
It's avidly restricting, so it's either going to be a dermoid again, or it's going to be a highly mitotic.
Can I give you a hint?
Yeah.
Because you have never seen it in the spine, you are slightly confused. The hint is that if I would have given you in CP angle, you would have
epidermoid.
Epidermoid, simple as that. Right? So this is an epidermoid. And that is why I gave you this hint that it is not enhancing, right? So it is similar to an epidermoid which is in the brain. So this patient is diabetic. Too much of history examiner has given you. And sudden paraplegia, I think I should not have given you this much. But what is your diagnosis?
They've got avid high signal on it throughout the cord, and also diffuse. The marrow looks diffusely abnormal as well. On T1, it's fine. So I've got T1, and then I've got T2, then T1, and
so this is a T2, this is a T1. Look at the cord.
It's a edematous on the T2 centrally, but in the because the diabetic, they're probably a vascular path, so I'm going to then hazard a guess that this could be a kind of ischemic event.
I want, you are right, but I want you to be very specific, very confident.
Yeah.
There's a pattern here. There is a pattern here. Think anatomy. That's the hint from my side.
You're going to be more likely to knock off your anterior spinal artery. And there's a hyper.
So what is your conclusion?
Concerned that this patient has had an spinal infarct.
Infarct, okay. So your conclusion is correct. Let me take over. Now, if you see here, this is the, in the cord, we know that the pattern is vice versa than the brain. The gray matter is central and the white matter becomes peripheral. We have got two arteries, rather three arteries. Anterior spinal artery is single and posterior spinal arteries are two. Key exam point to remember. Anterior spinal artery supplies the gray matter, which is this H. At times, the anterior spinal artery also supplies a bit of white matter surrounding it. So there are variations. And posterior spinal artery usually supply this. So this portion might be an overlap. But when you get this pattern, it is quite a pathognomic pattern. H, you get a H there. And this pathognomic pattern is because of anatomy, that the anterior spinal artery is blocked. And now, in literature, another sign which is given is owl eyes sign, cord infarction, which is this and this. My case here is even better, which gives you the whole H. And the key thing is, please remember the cord blood supply, and the most important artery, other than other arteries at various parts of anatomy, is which arises from the intercostal artery, somewhere between T7 and T10. The artery of, I can never pronounce this word, Adamkiewicz. I might be pronouncing it incorrectly. So that artery is the key artery. You won't pick it up on imaging, but one key thing is that I had given you this history here. You can ask the examiner this history because this is key, that the symptoms should arise within minutes in infarction. In the exam, they have shown this kind of case where a person, this is a long case in which there is a dissection, and with that, look at this, what is happening inside. And with that, there might be some abnormal signal in the vertebral bodies also. So this is a sort of a long case which you can get in the exam. And here is from StatDX, a case where there are multiple infarctions of the vertebral bodies. So you will get high signal in the cord on the sagittal sequence, but this H pattern, I'm not saying that all acute infarctions, cord infarctions will be H-shaped, but if they are very specific. Otherwise, the whole of it will be high signal. Look at this one. It looks more of a rounded type of a shape. Okay, what do you think with this kind of history, with the history of trauma 2 months ago, what is happening in the cord here? This is just for completion's sake.
So there's a extramedullary lesion that is on.
It is intramedullary. It is sitting on the surface, but it is intramedullary.
Okay, so an intramedullary, on the sagittal. Sorry, apologies, I can see that a bit better. So on T2, there's a hyperintensity. On T1, it's essentially isodense to cord. So a small hematoma that's now kind of maturing.
Okay, that's fine. Please remember that to localize a lesion, in the cord, is it intradural, extramedullary, intradural? Axial slice is the king slice. It's not the sagittal. So if you see here, this is it, and you can see that it is sitting within the substance of the cord. This is just for completion's sake that this patient must have had a contusion, and now there is a bit of hemosiderin there. So nothing much. Okay, this patient is a 10-day-old baby, forceps delivery, so a bit of birth trauma, and with that, the patient is not moving limbs. So T2, T1, T1, T2, T1, T1, T2. Over to you.
So I've got layering of T1 hyperintense fluid in the ventricles, suspicious for intraventricular hemorrhage. There is also hyperintensity surrounding in the periventricular kind of corpus callosal area, which could be consistent with hemorrhage as well in the context of traumatic birth.
What's happening in the cord?
There is high signal in the. There's low on T1, high on T2, at the kind of atlanto like kind of yes.
So how will you call it? What word will you use?
Contusion.
Contusion. That's fine.
Yeah.
So this is a case of what we call scivora, which is spinal cord injury without radiological abnormality. And by the way, this word is an old word. It is coined before MRs, etc. Radiological means there is nothing on the plain X-ray or a CT scan. So the point is that this can happen, and this was a birth trauma case. So T1 post contrast, T2, and this one is T1 post contrast. Over to you.
So I have got a lesion that has got a avidly enhancing nodule and then pericystic cystic components that is within the high cervical cord. It's relatively central. The nidus is eccentric.
Conclusion?
Thinking this is most likely to represent a hemangioblastoma. A hemangioblastoma of the cord.
Excellent. So this is a classical hemangioblastoma. Please remember that they might not have any cystic component. So the lesion itself, the tumor itself can have a cystic component, and then there can be a secondary serings also. So this is quite classical. And we have seen quite a few of them when we were covering phakomatosis. So, okay, what do you think is happening? 32-year-old male.
He's got multiple foci of T2 hyperintensity, both in the cerebellum, in the midbrain, the pons, as well as the cord. So there's T2 hyperintensities that are distributed in space. I would want to compare with others, but and also look at the brain formally to see if there's any classic features of MS, but highly suspicious of.
Excellent. So what will happen right now? I have given you these sequences in the exam. The examiner is not going to give you these sequences. The examiner is going to start the viva from this one. And if you see here, there is high signal here, and look even on this sequence, you can see some. So for example, look here. You can see plaque there. 10% of patients of MS, they present with cord multiple sclerosis. It's a classical viva scenario where they open up with a cord lesion. Now you have to think in differential diagnosis wise. When you see something in the cord, you have to ask for contrast. If there is a cystic component, think tumor, because demyelination, as in MS or ADEM, acute disseminated encephalomyelitis, should not have a cystic component, particularly at presentation time. Number two is look at the available, if any part of the brain is visible to you. On the other hand, you must ask for brain imaging. That is a must. Whatever you see in the cord, you know, before you say that this is it and I would like to see the brain imaging for confirmation. And please remember that the examiner might be showing you something like drop metastasis, etc. And something might be sitting upstairs in the brain. So that is a key to ask for. But in this particular case, something is sitting on these available sequences. And the discriminator between cord, ADAM and MS at times on the first presentation can only be made if there are some brain lesions. And so otherwise, you might not be able to make that discriminator. And similarly, if it enhances, this is a case of ADAM, by the way. You cannot make out that this is acute disseminated encephalitis just on the basis of imaging. And even if you give contrast, for example, it enhances or it does not enhance, you are nowhere. If it enhances, you will still consider a tumor in the differential. But follow-ups and things like that is also at times done. And you don't jump to tumor. But tumors, if you see expansion of the cord, if you see cystic component, if you see hemorrhage, and with that you see enhancement, go into the tumor ward. Yes, please. So this is a post-contrast, this is a pre-contrast, this is a T2.
Okay, so there is on T1 no perceivable lesion, and it's difficult to discern it on T2 as well, but there is definite eccentric enhancement within the thoracic cord. Having just discussed those features that are a warning of tumour, then this avid enhancement is definitely suspicious for tumour versus another pathology. So
rest of the cord shows this high signal means that there might be edema. So if you see here, now look at the fine touch. Let me change my mouse to pointer mode to be able to point more. Now, if you see here, this is enhancing, right? We'll come back to this. Now, look at this thing, enhancing, this thing, enhancing. Hint, think brain, what do you think is enhancing? If I show you the same thing in brain, you will pick it up.
It's like leptin and it's like packing
Excellent. Dura, right? Dura.
Yeah.
Right. Here what is happening, again, go back to your pathology and make your radiology. Something is sitting on the leptomeninges and then it is going into the parenchyma. From the leptomeninges, it goes into the parenchyma. Even here, if you see carefully, you can see something is there and then going in. And there is a lot of secondary edema. So, intraparenchymal lesion, pia mater is sitting on the cord, so, leptomeninges as well as dura mater. What comes to your mind?
Drop metastasis, like metastases from breast.
Okay, not a bad thought. Absolutely fine. Metastasis, please remember, go back to the brain. Let's go back to the brain. What are the processes which can happen in the parenchyma, in the leptomeninges, in the dura, and metastasis is one of them.
And then another one would be granulomatous,
for example?
Sarcoidosis.
Excellent. The greatest mimicker and the favorite of the exam. And this is sarcoidosis. And you cannot pick it up just on the basis of this imaging. But you remember when I showed you brain sarcoidosis, I told you that, my mantra of, know your pathology and make your radiology. What happens in sarcoidosis? It is basically a meningeal process. So from there, what happens that from the meninges, it can involve the neuro, it can involve the pia mater. Then it goes through the Virchow-Robin spaces, which are surrounding, the vessels which are going into the brain. We're talking about brain here. And from there it goes in. And I showed you cases where when they present like a tumor because part of it is intraparenchyma. So similarly here also what has happened is that it is on the pia mater and then it has gone in. But the key finding was this one. So this is the greatest mimicker in neuroradiology.
Hello?
In. So I hope everybody is. Let me go back to the basics because I have to now. Is candidate 2 with us?
Yeah, I'm still here.
So, by the way, for you, the screen crashed or what happened?
You froze and then I couldn't hear you.
Okay, so what happened was that there was an internet failure, and now, so I presume that everybody can hear me because you are hearing me, right? So we were talking about sarcoidosis, and look at this case. Now, you see, these are. Can you see my mouse, candidate 2?
Yes, yeah, I can see it.
So look here. So you can assume that it is sitting on the pia mater, and from there it goes in. So it will appear as if it is intraparenchyma. So these are various examples from the literature, StatDX. And interestingly, other examples, for example, here the conus, etc. So you remember there is a differential diagnosis in Chapman for conus lesions, and then the nerve roots here. So the deposits can be sitting there. So always don't forget sarcoidosis. And interestingly, as I told you in the beginning also, we have seen cases of bony sarcoidosis. So it can be anywhere in the spine. Similarly, metastasis can be anywhere. So metastasis can be intramedullary, just like in the brain, and they can be in the meninges, and this one was intramedullary metastasis. So this picture tells you that intramedullary, and this is meningeal or dural, and this one is, of course, in the bone. Any finding?
Yes.
Are there any metastases?
Yes, there are. Yeah.
And where are they?
They are drop metastases, so leptomeningeal enhancement on the post-contrast fat-saturated images on the posterior aspect of the spinal column throughout the thoracic spine.
Yeah, and you can see that how they have gone, and they with the same mechanism. Of course, they can go into the parenchyma. Thank you, candidate 2, and now we'll go to candidate 3. Please raise your hand.
Thank you so much. Thanks.
Candidate 2, be mentally prepared because we might go into a second cycle.
Right.
Candidate 3, you are with us, correct?
Yes, sir.
Okay, so here you are. This is another case. The same case, by the way, also had leptomeningeal hair and parenchymal hair in the brain. Yes, please. What's happening here?
So this is a superior sulcus mass lesion on the right side. I'm concerned that there may be a lung malignancy here, or it could also be a lesion coming from the spine. But in the first instance, I'd like to get cross-sectional imaging of the chest.
Can you go back to the details of the description of this lesion? Hint. What is cervicothoracic sign?
So a cervicothoracic sign is when there's a lesion which is going above the clavicle. And so this could be a lesion which is in the superior mediastinum, could be a thyroid lesion as well.
Cervicothoracic sign is a lesion, is a sign where, this is the extension of concept of the silhouette sign in chest radiology. What happens is that this is clavicle. Superior to the level of the clavicle, the lung apex in an AP dimension is quite thin. There is not enough air there. So if a mass superior to the level of clavicle has got a crisp and sharp outline laterally, means it is crisp and sharp because there is interface of air anterior to that. On the other hand, if the mass is sitting anteriorly within, then what happens is that the lateral margin will not be crisp and sharp. This is known as cervicothoracic sign, which is a classical exam sign. In this particular case, you see a mass. So this is the paratracheal stripe. You can say that this is widened. This mass is extending from here, goes superiorly. Superior to the level of clavicle, the lateral margin is well defined, meaning that it is in the posterior mediastinum.
Sorry about that.
Right? And then, so this is a classical favorite type of, and in this particular case, it was what was it?
So I didn't hear the initial part, but
This is a post-contrast.
So this is a neurally based lesion, neurofibroma or schwannoma.
Yes, yes. So it is going through the neural foramen, and it is that dumbbell type of a tumor. This particular case, if you see, is a T2 weighted sequence, T2, T1, T1 with contrast, then T2 coronal, T1 with contrast coronal, and an axial with contrast. Now, with that, there is a lesion sitting within the junction, the medullary medullary spinal junction, and it is going into the cranial cavity also. What is it?
So this is an intramedullary lesion. It looks, I mean, given that it's enhancing, it is a tumor, and given that it's within the, given that it's intramedullary, I think this could be a ependymoma or an astrocytoma.
And why have you made this judgment that this is intramedullary? Which sequences have you taken help from?
So I've looked at the T2 weighted, and I can see
So the key point here is that never make a judgment just on a sagittal. Never. You have to correlate it ideally with an axial. In this case, I have also given you a corona. And if you see here, this is the brain, and this must be the cord, and the lesion is sitting here.
Okay, so so it's actually an extra-axial lesion. Okay, so not extra-axial, as it is extra-axial. It is extramedullary intradural.
Very good.
So
Anything on this contrast enhancement here, which tells you what it can be?
So this homogeneous contrast enhancement.
Very good.
The lesion itself, I mean, I don't see any hemosiderin capping in the T2 weighted sequence. In this case, given that it's fairly, I mean, it's going over at least two vertebral bodies, I wonder if this is could this be a meningioma?
Absolutely, this is a meningioma. You see the intradural extramedullary lesions, two are the king, just like intramedullary lesions or intramedullary tumors, the two most common tumors were ependymoma and astrocytoma, and at times as hemangioblastoma. As far as intradural extramedullary, the king tumors are meningioma versus neurofibroma or schwannoma. So this one is a meningioma, and which enhances like anything. There is a bit of a dural tear here. But the key point to remember is that don't jump to conclusions on a sagittal sequence. Is it intramedullary or not? And always ask the examiner to go to, I want to see further. Now on this CT scan, it's a bit harsh, but on a CT KUB, can you see anything look into the spinal canal?
So there, in the axial single image, there's expansion of the foramina on the left.
And what will you be worried about?
So in this situation, it will be often a neurally based lesion, a neurofibroma, or a.
What will you like to do?
I mean, if we have a patient still on the table, I can advise a CT with contrast. Otherwise, not.
MR. Okay. So this is the lesion, and you can see that there is expansion. You can see it on the coronal, and you can see it here also. It causing expansion. And on an MR, the lesion is confirmed or not?
It is, yes. So there's expansion of the. I mean, at that specific level, I think it is L2 level. There's expansion of foramina with the nerve coming through.
That's fine. Let me take over. That you can see this T2 weighted sequence on this T1. This is the sequence. Again, once again, I want to make a point that when you do pre-contrast fat saturated, look at this and look at this muscle. And this looks a bit bright, so you have to develop your eyes on this. The lesion also becomes more bright than this, and then it enhances. And there is a cystic component. So remember that schwannomas, neurofibromas, they can have cystic component. You remember that I'm going into the world of CP angle tumors here. In the brain, when you see a CP angle tumor, schwannoma versus meningioma, you remember I told you various discriminators. And of course, one of the discriminator is that meningioma can have calcification. It can cause hyperostosis of the skull if it goes in. If usually schwannomas will go into the IAM, but another discriminator is cystic component. Schwannomas can have cystic component in the CT angle, but meningiomas will not have cystic component. Similarly, in spine, and yesterday or day before yesterday, I showed you a paraspinal neurogenic tumor which had cystic component. So don't get confused. Hemorrhage, cystic component, all of these things can happen. Is it a neurofibroma on this post-contrast? What do you think?
So it is quite eccentric and it's extra dural, I think, or rather it's extramedullary for sure. I'll look at an axial slice to see whether it is
very good.
Whether it's an extradural or
intradural. No, it was intradural extramedullary. You are right. On this post-contrast, just tell me, what is it? Is it a neurofibroma or something else?
I think it's a meningioma.
And why do you say that?
Because there's an element of a dural tail.
Excellent. That is the point I wanted you to say, that you can see homogeneous enhancement and you can see dural tail and dural tail. So this is this. Yes, please.
Okay, so these are axial slices of the abdomen with contrast of a 34-year-old male who has come in with history of trauma. Firstly, in terms of a trauma, I'm looking for any obvious traumatic injury. Don't see any free fluid in the abdomen. I'll look at the lungs on lung windows. Given that this is spinal.
That is a good one.
So I think there is some high density, enhancement within the cord, and you can see that in the bottom right image there is a osseous, or bottom left rather, is osseous bony structure going across the cord. This is in keeping with the stomatomelia.
Here you are. You see even today you took a bit of time to pick it up. It will be so unusual presentation on a CT scan. Anybody, once you pick it up, any child can say that this is a diastematomyelia. But if I show you a MR, just an axial MR, it will be too easy for you. So this is what I am. So from today onwards, this should be your checklist. Look into the spinal canal also. And so diastematomyelia, what happens is that there is a sagittal division of the cord, sagittal, right? Now, this can be a fibrous, division, or it can be fibrocartilaginous or bony. And it can divide the cord into two components. So, the classical case, okay, I'll come back to this. What do you think is happening here, candidate 3?
So these are pediatric radiographs of the lumbar spine. I think pedicles appear quite wide bilaterally. And I wonder if there's an infraspinal mass which is causing that. Because there's some remodeling of the vertebral, or the
What is this? What is this?
Could that be the osseous bony structure you see in the diastema? I'm not sure.
Absolutely. You see, the eye see what the mind knows. And this case has come in the exam so many times. And this is the same thing which I am showing you this. And please remember, if you go back to your Chapman and you see widened interpedicular distance, diastematomyelia is given there. So this is an osseous bar which is dividing and widened interpedicular distance, and with that the osseous bar. So unusual, but it becomes an exam case. If they show it on an MR, they will show, okay, this was the X-ray and the MR, and you can see how beautiful it is, but they are not going to show you this. So on this plain film, it's a struggle to pick it up. Maybe something is happening, but a bit of stretch of imagination. If you see the interpedicular distance might be slightly, but it's a harsh one. Nobody is expecting you. So, but this one becomes a, just 1 second, let me stop annotations for everybody. So annotations are now disabled, and I have to clear one of them. Right. So, I've shown you how on a CT they can show. I have shown you how on a plain film they will show. But in an MR, they are going to show you on a sagittal. And then when you will ask the axial, then it will make sense to you. So what is the clinically important finding here? Candidate 3.
So the tethered cord, which you're concerned about.
Say again, please.
Tethered cord.
Excellent. So if you see here, diastematomylia can be associated with a tethered cord. If you look carefully, look here. This is the distalmost portion of the phylum, and it has got a high signal here. This high signal is beautifully seen on an axial T1 weighted sequence. This is a lipoma. A lipoma or a fibrolipoma here is also considered an incidental finding. But in this particular case, what is happening that it is tethering the cord. Usually, the conus is in 90% of the patients, it is at L2 level. So this is the conus sitting here. Usually it is up there at L2 level. In about 10%, it might be at L3 level, but it should not be sitting here. Now, cord tethering can be symptomatic, and these patients might present to you at the age of, let's say, 20, 25, and they will have a lot of symptoms. So at times they do surgeries and where they remove this attachment here, and that helps them symptomatically speaking. Okay, over to you.
So
look at this cord. What is happening?
So on this T2 weighted sequence, there's significant myelopathy.
Sorry, let me explain to you, because the sequences are not ideal. This is a T2, this is a T1, this is a close-up T2, again T2, this one is T2, this one is post-contrast T1, this one. Over to you.
Okay, so on the sagittal T2 weighted sequences, there's high signal within the cord itself, and the anterior aspect of the cord, especially in the cervical region, appears a bit irregular. And this is also seen in the T1 weighted sequence. In the close-up view, you can see low signal intensity projected over the CSF. These appear to be vascular. And this is on the axial images, you can see the tiny low signal dots circumferentially around the cord itself. And in the post contrast, there is some enhancement more peripherally around the cord. I think this is a dural arteriovenous fistula.
Excellent, well done. Now, dural arteriovenous fistula, I used to think that it is slightly beyond 2B, but it started coming. And that is why I say the bar is going up and up in the exam. There are many types of vascular malformations in the cord, and this one is the most important, which has come in the exam quite a few times. And now I understand why it is important, because now I have seen about 3 or 4 cases in my clinical experience, should I say, where these patients have presented with some symptoms, just like a GP referral or things like that, and actually there was a dural AV fistula, and it was missed because the radiologist would not see it, because they were not neuroradiologists. They were not, their eyes were not trained to pick it up. Anybody should be able to pick it up. Basically, there are 5 types of vascular malformations which are important, and it's too complex for the 2B world. So forget about most of them. But this is known as type 1. Dural AV fistula. Look at this word, dural AV fistula. There is a fistula which is somewhere sitting on the dura, and because of that, the vessels which are sitting on the pia mater, they become prominent. And because of that, what will happen that there is a venous congestion. Because of venous congestion, there is venous ischemia, and there will be edema of the cord. So the cord will be high signal. Key thing is that look at the anterior surface of the cord. And the anterior surface of the cord will give you serrated outline. This is what I call the Rambo knife sign. This is Mr. Rambo, 1983 movie, and this is a survival knife. And look at how it is, the serrated outline to cut trees, this one. So this is Rambo knife sign. And develop your eyes on this. This is dural AV fistula. Other cases from STAT-DX for dural AV fistula, same thing here. And you can see that the cord signal is increased. Nobody is going to ask you, MRAs or things like that. Just to make a point that sometimes cavernomas, just like cavernomas of the brain, there can be cavernomas of the cord. Simple as that. And you remember the radiology of cavernomas. They will, popcorn appearance can be there. They can be, if they are small, they will be low signal on gradient echo sequences. Please remember the T2 weighted sequence, which we do in the spine, is actually a gradient sequence. And so it will also appear low signal, just like a contusion. So this should be the differential. Okay. This case has come in the exam quite a few times. I want you to just concentrate on this sequence, this sequence, this sequence. T2, T2, T1. Over to you.
Okay. So
this patient had operation for TB, now bladder dysfunction. Over to you.
Yeah. So in the comparing the top and middle image on the right side, I note that the cord appears to be clumped and appears to be absent in the second image. And in the
conclusion,
I think it's clumping of the cord. So remember the name.
Is it the cord?
Right?
Is it clumping of the cord or clumping of the nerve roots?
Of the nerve roots, the cord.
Yeah. So what is your conclusion?
So I think this is secondary to the previous TB infection, and the cord is tethered. I think it's clumped.
The cord will not be tethered. These are the nerve roots. You see, we are in the chorda equina. We are distal to the cord.
Yeah. So I was going to say clumped roots, but I can't remember the name now.
Yeah. So this is what I was trying to ask you. This is chronic arachnoiditis.
Yeah.
Right? Clumping of the nerve root. So what happens is, now if you see, this of course has got treated TB here, And look at this, you have to develop your eyes because this is a very important exam case, and I'll show you multiple examples of this, where clumping of the nerve roots or thickening of the nerve roots on a T2 weighted the sagittal, they will appear like this, and the examiner is going to open the case on a T2 sagittal. Once you pick it up, then you ask for axials. Here what is happening, that slice was going through at this level actually. And you picked up the finding very well. What happens in chronic arachnoiditis, so this is how the usual thecal sac and the nerve roots should be. And here, where are they? They are just, clumped right and left with the dura. So this is known as empty thecal sac sign. Empty thecal sac sign means this is chronic arachnoiditis. Please remember, acute arachnoiditis, the nerve roots can enhance and they will be thickened. But this is chronic arachnoiditis.
Yeah. Sorry, forgot the name.
Okay, so this case the image quality here is not very good. But having said that, this case has come in the exam. So this patient again has got a birth trauma and not moving the upper limb. Now concentrate on this T2 weighted sequence, coronal. Concentrate on this parasagittal T2 weighted sequence. What comes to your mind? What is your diagnosis?
Just having a quick look at it. So there's high signal laterally, especially on the right side in the top middle image, adjacent to the cord, and there's high signal going into the foramina, looking at the parasagittal images. I think this could be lateral meningoceles or pseudomeningoceles actually.
Yeah. So you see, if an examiner want to show you, they will show you on a sagittal. They will open the sagittal, and in the parasagittal, you will see CSF going into the neural foramen. And on an axial, it becomes much easier. So this is the axial, and you can see that the CSF is going there. So this is another case where you can see it here, and you can see it here, and particularly here. So pseudomeningocele is an exam case, and basically this picture tells you what happens. There is avulsion of the nerve root, and the dura tear is there, and the CSF, it goes out. So this is from StatDX, pseudomeningocele, another one from StatDX. Last case, and then we will take a break, and then candidate 4. Yes, please. This case I have shown you in MSK. It's a revision case, and today my mandate was not to cover extra dural space, which we have covered, but I thought that maybe for signals, it will be a good case as a revision. Over to you.
So in the T2 weighted image in the bottom left, there is abnormal signal within one of the thoracic vertebral bodies.
So I am not interested. This was a known fracture. I know it.
Okay.
Look at the marrow. Hint.
So on the T1 weighted sequence, I think this is a relatively middle-aged person. There's significant loss of signal, loss of T1 signal, and there's fairly high T2 signal. So I wonder if this patient has got a global pathology, for example, significant infiltration of the marrow.
So which sequence? You said that there is high signal on T2. What do you mean? On T2, this one or this stir?
Sorry, I meant the stir, yeah. And there's no signal on T1.
Right. Okay, so if you see this case, and this is very important for the exam, there is diffuse marrow abnormality. For example, if you see here, look at this. Initially, you don't pick up that something is abnormal, but look at the formula that on a T1 weighted sequence, the marrow should be lesser in signal intensity than the intervertebral disc, or if in another part of MSK, lesser than the adjacent muscle. So this is lower than this. Then look at the stir. T2 is rubbish, absolutely for marrow. Don't go to T2. Go to stir. And on a usual stir, it will be low signal, and this is high signal. Whole of the marrow is abnormal. So the eye see what the mind knows. Look, this is a normal example. Look at this marrow, T1 high, and on stir it is low. Look at this intervertebral disc, it is lower as compared to the marrow. This was our case, and this is diffuse marrow infiltration. And diffuse marrow infiltration, when it comes to the exam, multiple myeloma, metastasis, these are the top two. Lymphoma can also be in the differential. This is another case in which there is diffuse marrow, and this is metastasis. And then super scan, this is the type of case which will come as a super scan. If you see this spine, everything is abnormal. And super scan per se, of course, is an exam case. So we stop here. I will stop sharing because I think I have to put a slide there. So after, it's a 5-minute break. After the 5-minute break, candidate 4.
Thank you very much.
Thank you, candidate 3. Is candidate candidate 4 there? Can you hear me?
Hi.
Okay, and can you see my screen, this super scan slide?
Yeah.
Okay, so now I want you to describe findings. This case is a trauma case. We know that there is a fracture there, and this is the fracture. This is a T1, this is a T2, and of course I've given you some axials also. What are the findings?
Sure. So these are selected images of MRI thoracolumbar spine, demonstrates T1 vertebral body fracture. There's loss of vertebral body height and also indentations of the posterior vertebral body margin into the spinal canal, compressing the cord at the L1 region. There is myelopathic signal change, evidence at the cord at the region. And looking specifically anteriorly for any paravertebral collection.
How will you report this finding here?
So I can see there is abnormal cortical bulge posteriorly, and there is also complete effacement of the spinal canal with cord compressions at this level.
Okay, and what is happening here? Anterior to my mouse, in between the mouse and the vertebral bodies.
In between your mouse and the vertebral body. So I can see there is the conus at L1 region, and between your mouse and the vertebral body there is a area of increased T1 collection. Tracking anteriorly.
Yeah.
So in keeping with the epidural collection.
Excellent. So please remember, epidural hematomas can be spontaneous also in the cord, and but having said that, in trauma, just wanted to show you an epidural hematoma. Here, clinically speaking, the most important points are that because of this compression, there is retropulsion of the bony fragments into the spinal canal. This is what you have to report, and which is causing cord compression. And then there is high signal within the cord, and there is a low signal on T2 and high signal on T1 means cord contusion. And this is a hemorrhagic contusion. Hemorrhagic contusion in a trauma case is taken as a sign of bad prognosis. That's fine. This is a case which we will skip, but just to make a point, in the exam, these kinds of cases can come where multiple findings are visible on the available sequences to make a conclusive type of diagnosis. If I don't show you other sequences, for example, here you will say low signal on T1, high on STIR, multifocal. So this is in keeping with metastasis. But then on the available sequences, you can see multiple lesions in the liver. So metastasis there. And then on the SCOUT, you can see that there is a lung carcinoma, means that is the primary. So always look for multiple findings. So in the spine, for example, you are looking at the cord and something might be sitting in the brain. Or if you go to parasagittal and something might be visible on the lung. So that is what is checked in the exam. Okay, not an ideal sequence because I have not given you a fat saturated post-contrast sequence. It should have been a fat saturated. But having said that, I just want to teach you something here or to ask you something. So this patient is post-op and there is a laminectomy on the right side, and the patient has got recurrent pains, etc. They have asked for imaging again. So we have done a T2 weighted sequence. And then we have done here, this thing here, this line here is contrast enhanced T1. This line is T1 without contrast. Over to you. What is the important point? How will you report this case?
So looking at the T1 pre and post contrast, I can see there's an enhancement of the soft tissue at the site of laminectomy on the right side. So this is in keeping with inflammatory changes at this region, but I'm also looking specifically for any sign of epidural collections or abscess. I don't see any sign of that.
So they are not clinically worried about infection. They will always be worried clinically about infection. They are just worried about, is it a failed VAC syndrome or whatever. What is the important point to remember here? This is what I am trying to ask you.
Well, post-op 8 weeks, and we have enhancement in the muscle at the surgical tract. So I'm thinking of granulation tissue will give enhancement post-op.
Okay, let me take over. You see, the key thing to understand is that in post-op spine, I'm not going into this the infection world. Infection will be infection, and they will be worried, and then of course you will pick up signs of infection. But the key thing is post-op fibrosis versus a recurrent or a residual disc herniation. Now, fibrosis enhances with contrast. Normal fibrosis enhances. And this is why I'm showing you this case. If you see here, this is on this T1 weighted sequence. Look at this epidural space, and it is low signal. You are not very sure what is happening. Then go here on post contrast, everything is enhancing. So don't confuse that this is infection or anything. This is just fibrosis. And if you see, this is the nerve root and surrounding it is fibrosis. On the other hand, this thing here is a disc, which is a residual disc or, recurrent, whatever. But usually, it all depends how experienced you are. MSK radiologists who have developed their eyes, they actually can differentiate between fibrosis and disc without contrast. But lesser beings like myself, we give contrast actually. And in my department, we usually give contrast for about 2 years or so. And after that, there might not be any role of contrast. So to differentiate fibrosis versus recurrent disc. That is the point here. Okay, degenerative disc disease is the most common clinical concern in your practice, and more MR lumbar spine are done for degenerative disc disease than anything else. I have no time to teach you degenerative disc disease and the terminologies. But having said that, there is a disc herniation. I am trying to see your concept and what words are you going to use. This is T2, T2, T1, T1, and this is axial T2. This is axial T1 and T2, T1 and T1 axials. Over to you.
So select the images, lumbosacral MRI, demonstrate L5/S1 disc dislocations, and I can see there is these extrusions and also extending inferiorly. I'm looking for any discontinuation of the disc material from the donor. I can see that on the T1 image, which in keeping with sequestration. Looking at the axial slice.
Fine, you've done well. And what is your conclusion?
So, finding in keeping with these sequestrations causing spinal canal narrowing.
Okay. So if you see here, you can read it. I don't have time. but in our ST2 teaching, I will teach this in detail. The nomenclature of disc herniations and what is a protrusion and what is a broad-based disc protrusion versus a focal or a narrow disc protrusion, and then what is an extrusion, and then extrusions can be with sequestration, as in this case. And here you see that there is a sequestrated disc fragment. It has gone into the level of lateral recess here, and it is compressing the right-sided descending S1 nerve root. So all of these concepts we will cover later on, but I just wanted to highlight that sequestrated disc fragment is an exam case. It has come in the exam. What will you call this? It is in the parameters of degenerative disc disease. If you see here, and you can see this high signal here. Terminology is my question. Is terminology here?
Yeah. So it looks like broad-based disc bulge to me and also narrowing at the lateral recess.
So I will stop you here. This is the old terminology for this was an annular tear, and now I think the new recommendation is high intensity zone. So annular tear can be very symptomatic. Please remember this. It can cause pain. It is not herniation. Basically, in disc herniation, what is happening? If you look here, this is the nucleus pulposus, which is the central part of the disc. And this is the annulus fibrosus, which is black to your eyes. And what is going to happen in disc herniation, that the nucleus pulposus is going to extrude out. So the definitions of protrusion, extrusion, etc. For example, if you go back to this case, this has come out and then it has gone inferiorly, and then there is a fragment which has separated. So that is known as disc extrusion with inferior migration with a sequestrated fragment. On the other hand, it has not come out completely. It is touching the edge, but it has not protruded out. So this is known as annular tear according to the old terminology, which now people use high intensity zone. So I just wanted to highlight this. More for your day-to-day reporting, but having said that, in the exam, if there are multiple findings in a case, and there is a disc extrusion at one level and this annular tear at another level, maybe you should know it. That's why I'm showing it to you. It is in the parameters of degenerative disc disease. By definition, it is not a herniation. So just concentrate on this slice. What is happening? Just this slice.
Right, so that is a T2 weighted image. Demonstrates abnormality in the left side of the pelvis. And there is abnormality of the musculature and also the pelvis.
So what is this muscle?
Right psoas.
And what is happening to this psoas?
And so it is fluid filled within the psoas, so we can keep. So
I just, this is a very simple case. Anybody will pick it up. Just wanted to make a point here. Psoas sepsis has come in the exam and it will come again. TB, for example. I've got very good cases for psoas sepsis, is more subtle, etc. I don't have time. But having said that, remember, they will show it to you on an axial slice. And that is why I'm showing you this. They will begin with an axial slice. And even on a T2, if you see replacement of, you will be looking into the spinal canal and things like that, and the lesion might be, and that will give you an indication that something is wrong. So they might start with an axial, and this is the point which I wanted you to highlight. This is a psoas sepsis, and psoas sepsis is very common with TB. Okay, now, this patient has got backache with fever. The clinicians are worried about infection. This is a T1 weighted sequence. The limitation is that I have not given you fat saturated pre and post, which it should have been done with. So the protocol is not perfect. Having said that, the finding can be picked up. This is a T1. This is a contrast enhanced T1. This is a T2. And this is also contrast enhanced. You know, it's written there. These three, 1, 2, 3. And these three. Over to you. What do you think?
So, such the selected images, I can see there's abnormality at the spinous processes at the level from L4 down to LS1 level, and there is enhancement on post-contrast imaging. And looking specifically at the disc, I can see there is also abnormal enhancement at the L5S1 disc material.
So what will be your conclusion?
So given that the patient is, this is concerning for spondylodiscitis.
Spondylodiscitis. So, okay. So what happens is that when there is a spondylodiscitis, the disc, look at the T2. And when there is high signal, higher than the nucleus pulposus, you should be worried about that. Then gradually, and on a contrast enhancement, look at enhancement, which is there. Then look at the word spondylodiscitis. So the adjacent end plates will be involved. In this case, they are low signal on T1, but it is enhancing. So it is early spondylodiscitis. On the other hand, this is a more important exam case. The previous case was just to develop your eyes. Now, on this case, we have got a T1, T2, a stir, a pre-contrast, and a post-contrast. What is happening? Look at this level.
Yeah. So looking at the pre and post-contrast images, I can see there is signal abnormality and also abnormal enhancements of the L5, 4, 3, 2, 1, L1, L2 level, and also there is enhancement in the vertebral end plates as well as the disc, including with spondylodiscitis. In my normal practice,
what is happening here where I am pointing out?
so I'm looking specifically for epidural apps collection. I can see there is evidence of enhancing epidural collection on the post-contrast images anterior to the spinal canal.
So the clinician says, "Can you drain it for me?"
So this collection is located anterior to the spinal canal. Now we're at the level below the conus.
Okay, my question is basic. Is it drainable?
And I don't think it's drainable.
Okay, let's go back to the basic. Is it an abscess?
It is. There's no enhancing more. So it's a.
Everything is enhancing, right?
Yeah.
When everything is enhancing, it's not liquefied. You remember yesterday also, day before also, I told you the concept of phlegmon versus an abscess.
Yeah.
This is a critical for the exam and in your real world also. Let me give you an example of a liver abscess. What happens in a liver abscess? You are on a Friday and you do an ultrasound and there might be something, you do a CT and okay, and the clinician tells you, can you put in a drain? And you say, no, please wait, let's rescan on an ultrasound on Monday. If it is liquefied, I'll put a drain for you. So please remember the difference between abscess versus phlegmon. In head and neck, it's a very important exam or viva question. Subperiosteal abscess of the ethmoid sinus. And the clinicians will say, okay, where can I, is there an orbital abscess or not? And if it is a phlegmon, you just tell them that there is no drainable. So basic concept is, just remember it like this, that phlegmon is inflammatory tissue, right? Which enhances. And then when there is pus formation, that is an abscess. And by definition, pus will be liquefied. There will be surrounding enhancement, but the pus will not enhance. In this particular case, this is all phlegmon. You see on a T1 here, and on a this is all phlegmon. It is not an abscess. So if you see here, this is spondylodiscitis, and this is how it goes, and then there will be end plate irregularity, etc. With that, this is in our case, at that the point when that scan is taken, this is not liquefied. This is an phlegmon. And here comes the same point from STAT DX. You see here, all of this, the dura is enhancing, there is a bit of phlegmon. Within that, if you see here, if this was a T2, if you see this portion here, which is not enhancing, you will call that particular portion as abscess. Because the clinician will say how big it is. Then you can measure this component. Don't measure everything else. When you do a rescan, it might enlarge in size because it might liquefy. On the other hand, because of antibiotics, it might reduce in size. Okay, last pathology, and then we will go for a few viva cases in a PACS format. Over to you. This is a baby, 3 months old baby. This I have given you only contrast enhanced scans, and these are through the conus, and these are axial through the conus. Over to you.
Sure. So post-contrast imaging of a 3-month-old baby spine, I can see there is an enhancing, there is a high signal abnormality at the spinal canal located posterior to the cord. Displacing the cord. No, actually, it's displacing the cord. No, sorry, I take my initial assessment back. So on the imaging, it demonstrates the cord signal. The cord itself is enhancing homogeneously throughout.
Excellent.
In a 3-month-old baby, I'm thinking.
And what is happening to these nerve roots? Look at these nerve roots.
Yeah. So the nerve roots
are enhancing, right?
Yeah.
And if you look carefully, even here, those nerve roots are enhancing.
Yeah.
What is your conclusion?
So I'm thinking down the road of infective or inflammatory process in a 3-month-old.
Name names.
And so meningitis is it could be.
Meningitis can be in the differential, by the way.
Okay. Encephalomeningitis.
Initially, the baby's lower limbs were not moving very well, and then gradually it's becoming more unwell.
Okay, so I'm thinking of Guillain-Barré syndrome as well.
Okay, very good. I'll take over. Now, if you see here, we are in the last differential of this chapter, and then we will just do a few viva cases. Now, lesions related to cauda equina. In the latest Chapman, this is a new heading which has come up. So just because I feel that many at FRCR 2B level, they get a bit confused. I have already shown you a myxopapillary ependymoma at that level, right? But I'm showing you a few inflammatory processes. Now, if you see here, intraspinal masses, and here is the second subheading, intradural extramedullary. Intradural extramedullary. All of these can simply add to cauda equina. Simply add. Simple formula. Just remember these. And the most important will be leptomeningeal metastasis and other leptomeningeal processes according to Chapman. And within that, if you read it, the most important are sarcoidosis, the greatest mimicker, and meningitis. So when meningitis of any type, for example, it can be viral meningitis, it can be tuberculous, it can be pyogenic. There will be enhancement of the nerve roots, etc. So then, if you go here, lesions related to cauda equina. Look at the first one, any intradural extramedullary mass, which was this one, intradural extramedullary mass, these two. And with that, add a few tumors like myxopapillary ependymoma. Paraganglioma for me is not an exam case. Phalanx terminal lipoma, I have already shown you. You know that tephret cord appearance. Guillain-Barré syndrome, GBS, is up there. It is more chronic condition, just like Guillain-Barré, chronic inflammatory. In Guillain-Barré, what happens is, remember clinically, it's an ascending inflammation. So it ascends from the nerves, it goes into the conus, it goes into the cord, it goes all the way upstairs into the brainstem, and then the patient dies. But they don't die now. They do recover, and particularly if you got ventilators, etc. Previously, the prognosis was not all that good. And then other radiculopathies like CMV, and this is important because you will see in patients of AIDS. So I can give you a long case there, and you have to make 2 + 2 is equal to 4. So if you know it, only then you can. So AIDS, remember that. So, the radiology will be the same. The pathology will change. Look here, another case of Guillain-Barré. Key thing is the examiner is going to show you a T2 sagittal. On a T2 sagittal, you ask yourself, oh, look at this. Something is there. These are thickened nerve roots. And in this particular case, you can see on this post-contrast, this is post-contrast, this is pre-contrast. You can see these are enhancing. And then you will ask for an axial. Even here, you can ask for an axial, and you will see thickened nerve roots. Once you see them, then you will ask for contrast, and they will enhance. So, look at this case. This is the last case. Over to you.
So 17-year-old under the care of hematologist, I can see there's abnormality at the corticoidal root. With on the T2 images, I can see there's there's a thickening of the corticoidal root. Under the care of hematologist, make me think that the patient could have underlying hematological disorder and with result in cirrhosis. But the thickening of the...
So the point is that anatomically speaking, this is the conus. So what is thickened here? That is my question to you.
Corticoidal.
What do you mean corticoidal? The nerve roots, right?
Yeah.
The nerve roots. So go back to axials. Now look at this T2. What is happening to the nerve roots? This is the conus, and what do you think is happening?
So the corticoidal nerve roots are thickened and clumped.
And on post-contrast, they are
enhancing.
Simple as that. And you can see that enhancement here also. Right?
Yeah.
So if you find this, develop your eyes on this T2 weighted sequence that they are. So this is a case of, the differential as we have covered. And interestingly, this was a case of, there is a, we call it lymphatic meningitis, where this is a very rare presentation of a lymphoma, which presents here on the nerve roots. But having said that, nobody is asking you to pick that up. You can just go to the differential, as in metastasis. Lymphoma also can occur anywhere. It can be intramedullary, it can be extramedullary intradural, or it can be extradural also. So this was a case of lymphoma. Now, before I go to long cases, few viva cases, what I'll do is I will give one odd case to all of you. Candidate 4, you remain with me, and after this I'm going to go to candidate 1. Before that, if you can use this QR code for the feedback form for today, it will also be in the chat box. I will display it in the end once again. So candidate 4, you are still with me, right?
Yeah.
Just 1 second, please. COVID pneumonia with fever, back pain, and sciatica, they were worried about spondylodiscitis in this case. Can you see my screen?
Yes, I can.
Okay, let's try if I can give you the remote. If it works, fine. Otherwise, maybe I will scroll for you. So now the control is with you. Can you scroll through it? Keep going.
Okay. So this MRI T1 weighted.
T2. This is T2.
Sorry, T2.
Okay, can you go to the midline, please? Just midline where the cord is visible. Yeah. Just stop here.
Okay.
Now, regarding the cauda equina, what do you think?
There is increased signal in the cauda equina nerve roots on the statutory image here.
Right? Agreed? Okay. Please continue. Keep scrolling.
Okay. So MRI series 2, and this is T1 weighted.
Keep going.
Keep going. Okay.
Now, go up and down and try to pick up findings. This is a T2 weighted axial.
Okay. T2 weighted axial. And so now I can see there's abnormality here. Oh, sorry. So I'm coming up again. So starting from the first slide that I have got here, these are cauda equina nerve roots. So there is crowding of the nerve root and also thickening of the nerve roots.
Something anteriorly pushing it. Now here, go next slide. Here, okay, go back. Yes. So anterior, your finding is right about crowding. Something anterior to the thecal sac. What do you think? What is? I'm taking over the mouse. What is this, for example? Can you trace it? And next slide, please. Yeah, just stop here. Can you see something? Right?
Yeah. So
let's continue to the next series. Please continue to the next series.
Okay.
This is which sequence?
So this is pre-contrast.
Excellent. Fat saturated pre-contrast. Please go to the next series. And to the next. This is also pre-contrast. Okay, now you give me your diagnosis.
Okay. So on the post-contrast
you go to the
images,
sagittal and you go to the axial also. This is post-contrast. Make up your mind and give me your diagnosis.
okay. Okay, so I can see there's multiple epidural abscesses causing.
Go back.
Sorry.
Yeah. Okay. There are multiple
epidural abscesses.
Right.
Effacing the cauda equina root posteriorly and causing crowding of the nerve root.
Okay, fine, excellent. So I am going to. So basically, you have picked up a spondylodiscitis.
Yeah.
Okay, let me go through it with everybody. Now, this is a T2 weighted sequence. The key finding here is look at this, disk. This disk is decreased in height. Now, when the disk is reduced in height, it is degenerate, means the nucleus purposus is degenerative. It should not be high signal, and this high signal is like water. It is more than even this. So this is abnormal. And then now, retrospectively speaking, if you go right and left, now you can see that something is sitting there and it is causing indentation of this thecal sac. The CSF is different. You are absolutely right. Whole of this quana, it is compressed and there, they are sort of thickened nerve roots. On a T1 weighted sequence, look at the marrow. Look at the end plate carefully. And look at this end plate, it is crisp and sharp outline. Look at this end plate, and this end plate has got irregularity. This end plate has got irregularity. And then we go to T2 axial. And on this T2 axial, up here, you can see CSF here, you can see the nerve roots. Then something is happening here. It might be the abscess or might be a disc lesion. Then this is that abscess, and here definitely that abscess is visible, and you can see that mass effect. And now on post contrast, it will become clear that actually this is an abscess, and you will see on post contrast, it will not enhance. So from here we jump to the post contrast, and now you can see that the end plate is enhancing and the central part is not enhancing, means there must be a liquefied matter there also. Now part of it is phlegmon, but part of it, which is this thing here, which is fluid intensity, is all abscess. If you can see within the thecal sac there is enhancement, so it comes to your mind what is enhancing. So the nerve roots are enhancing, and this is a sign of acute arachnoiditis. So please remember, chronic arachnoiditis is clumping. In acute arachnoiditis, which can happen because of any kinds of meningitis, there will be enhancement of the nerve root, and you can see this epidural abscess there. And if you trace, for example, look at this nerve root, they are enhancing. So enhancing of nerve root, and you can see how badly it is. This is a case which will, derive benefit from maybe decompression. Okay, candidate 4, thank you very much. We go to candidate 1, please.
Thank you.
Are you with us, candidate? Okay. Can you see this case 3 written for you?
Yep, 71-year-old female fell at home, fracture L1.
Let me give you the mouse control. Take over, please. So this patient fell at home. There was a L1 fracture, and the orthopods, they said we want to do an MR also just to evaluate if anything else is happening. Okay. So this is a T2 weighted sequence. Just stop it. Just stop it. Yes, please continue.
So I can
describe it.
Yes, so I can see a compression fracture of L1 with loss of the height significantly in the central portions. It appears to be compressed centrally. I can also see an endometrial mass which is unusual for a 71-year-old to have endometrial cavity this size.
Please continue. Next series.
So this is a T1 weighted image. So in the T1 weighted image, there's low signal within the abnormal vertebral body, and there's also high signal within the cord. There's also a thin vertical low signal line within this high signal intramedullary structure.
Please, next series. Stir sequence.
Okay. So on the stir sequence, once again, I can see an abnormality in the L1 vertebral body. It's high stir signal compared to the muscle. And I can also see high stir signal in the endometrial cavity. Having a look at the cord, there isn't significant retropulsion within this cord, and there doesn't appear to be any extension of the abnormal signal within the posterior elements of the spine. Having a look at the cord, there's a focal area of expansion local to this vertebral body.
Please continue. This was a stir.
Okay.
Okay, go back and give me your diagnosis. Can you go to an image? We are seeing the red color right now. And stop in the midline. Give me your diagnosis.
So I'm concerned that this may represent a metastatic deposit rather than a traumatic fracture with a possible lesion within the cord.
Okay, now go beyond red. You know those red slides? Please continue.
So now I have, axial T2 weighted image. So in the T2 weighted image, I can see an extramedullary intradural lesion, which is causing mild mass effect on the cord at this level.
Please continue. T1.
So there's also high T1 signal within this lesion.
Please continue.
Okay, and this is a this is a T1 fat sat.
T2 star.
T2 star. Okay, I can see intermediate signal within this area.
Please continue. So, okay. So, this was a gradient echo, the last sequence. This was a gradient echo sequence.
Okay.
So, what is your conclusion now?
So, there's high T1 signal within the cord, so the differentials for this would include hemorrhage. However, I'm trying to find the diagnosis which will put everything together and introduce.
There are 3 different diagnoses.
Okay, so I think one diagnosis would be endometrial cancer.
So, very good. What will you advise for that?
So for the endometrial cancer, I'd recommend an MR pelvis gynae protocol to further assess the lesion and a CT thorax.
And for other things?
CT thorax abdomen pelvis to stage the cancer.
No, just give me your diagnosis on the other 2 findings.
Oh, the other things. Okay. So so the cord lesion is high T1, quite homogeneous signal.
Can I give you a hint? It's an incidental finding in the cord.
So yeah, so I thought it was a lipoma, essentially.
Lipoma, here you are. Okay, I'll take over. You see, the the teaching points here are, first of all, this was well picked up, the endometrial, this was an incidental finding. Any endometrium which is more than 4 millimeter in thickness, in postmenopausal, call it. And MR is not the correct answer. The correct answer is I will refer to the gynecologist for hysteroscopy. Please remember our role for endometrial carcinoma is not diagnosis. They have to do a hysteroscopy. They will do the biopsy and then we will do an MR. MR is for staging, just like rectal carcinoma. So there is no role of MR without a biopsy because there can be a differential. For example, polyps and hyperplasia and etc. etc. Now, as far as this finding is concerned, this is an incidentaloma. This is a lipoma. Now, on a T1 weighted sequence, the learning points here are, I have not, because that was not my mandate, but in real world, what happens? Many a times we get a clinical referral where they will say, is it an osteoporotic fracture versus a metastatic fracture? And so there is a lot of literature on this. I'm not teaching you in detail, but the key finding in this particular case, which goes in favor of osteoporosis, is that there is a fracture line. Please remember that there is no fracture line in a metastatic fracture. Number two, is there a bulge on the posterior surface? If there is metastasis of something, there might be a bulge. Is the intervertebral disc next to has it got a biconvex appearance like this? So this is osteoporosis, and with this, a trivial trauma cause all this fracture. So this is an incidentaloma, lipoma, and which we have covered. And we know that lipomas can be, on this stir sequence, it just loses the signal and fat saturated sequence. The last sequence which I showed you was a gradient echo T2. So we will, so of course, on axial also you can see the same thing, and you can see this is an intradural extramedullary lipoma. And previously I showed you an intramedullary lipoma also. And your book also tells you that it can happen in both series. Okay, you've got another case, so let's crack on. What is this?
Okay. So I have a sagittal T2 weighted image of the spine in a 45-year-old male patient. So in this sagittal T2, I can't see any significant stenosis. There's normal signal within the cord. So on T1 weighted imaging, I can see a diffuse marrow abnormality where the vertebral body.
So what is your concern?
So in a 45-year-old patient, I'll be concerned that it may represent a malignant process such as...
Excellent. Go to the stir, please.
So on the stir sequence, the vertebral bodies are of high signal.
So conclusion?
So a diffuse marrow process.
Any abnormalities which
things like
supports your diagnosis?
Any other abnormalities?
Primary, I mean to say.
Any other abnormality in relation to this?
Yes, which can, your diagnosis is absolutely correct. This is diffuse metastasis. Can you see any primary on the...
Yes, I'm just going to have a look if there's anything in the lungs, if there's anything in there. So there is a...
Yeah, this one.
I think there's a mass here.
Excellent. Okay, I will take over. Well done. Now, this was well picked up. If you see here, the eye see what the mind knows. Actually, retrospectively speaking, you can see something here, in the mediastinum. But having said that, it is next to impossible to pick it up. Now, on this T2 weighted sequence, you are not very comfortable about anything. But as soon as you know that formula, that this signal is less than this is diffuse marrow abnormality. And if you look carefully, even the sternum is abnormal. So this is diffuse marrow abnormality. And then you go to stir, and stir is absolutely bright, which it should not be. The sternum is also out. And with that, you can see something in the mediastinum and lung. Actually, on the scout, the primary tumor was visible. And actually, this is a rapid reporting case, also a Viva case. This tumor, there's a tumor sitting. This is the tumor, and by the way, this was missed. So luckily, luckily means the patient did not suffer, because after 2 weeks, the scanning picked it up. But having said that, this is a nodule, and this per se is a FRCR case. It can come in the Viva, it can come in the rapid reporting. So, and this is a CT to make the point. Okay, thank you, candidate 1, and I'm going to candidate 2 now.
Hello.
Very interesting case. This is a long case for you. In the long case, just consider, can you see this case 1 long case written?
Yeah.
Okay, this is a long case. On this long case, there was an adrenal nodule, right?
Okay.
With that, the examiner has given you this MR, and the clinical is that the patient is numbness, both lower limb occurs with walking. Oh, some typo here, but just a bit of walking, and the patient is having a lot of problems. Over to you.
Okay, so I've got a sagittal MR T1.
Okay, go back, please. Go back. And let me take over the mouse, and I want you to just, sorry, I'm moving and you are not moving.
Yeah, I'm not touching.
Okay, look at the thecal sac here. What do you think is happening?
It's thickened and being pulled anteriorly, and there is high.
Okay, very good. Now, keep continuing. Next sequence, please. Next series. Keep scrolling.
Okay. So another T1 again.
Yes.
Yeah.
Stop. The same level where I had stopped you.
Yeah.
What is happening?
So it's iso-intense. The abnormality is iso-intense to cord.
Please continue.
So fat suppressed.
Stir sequence.
Oh, stir, sorry, yeah. Fluid sensitive. And
Okay, just hold
the
on.
abnormality again.
Yeah.
The abnormality again is similar to the CSF and cord.
Okay, please continue. Next series.
So axial now.
Yeah. Look at the thecal sac. Keep looking at the thecal sac. Stop.
Yeah.
Right? Please continue now to the next series.
Okay.
Okay, let's have a discussion on. I'll take over the mouse. Okay,
Yeah.
Let's have a discussion here. Now you have seen everything. What do you think is happening? Why is this thecal sac compressed?
They've got an adrenal lesion on CT, and then they've got clump. So the roots are all clumped together and then being pulled anteriorly. So I'm concerned that there's like an arachnoiditis or just deposits that are causing that pathology.
Look at this signal. Look at this signal. What is this signal? What is this signal?
This is the gradient echo, isn't it? So there's
No, this is a T2. So, and if I show you a T1, which was before, now this is signal, this is T1. What is this signal?
high signal, so it's fat signal.
Fat signal.
Yeah.
Conclusion.
So there's lipomatosis of the spinal canal.
Yeah. Have you ever seen this case?
No.
Okay. So, the point is that this is known as epidural lipomatosis, right? Look at this picture. Look at this picture. And Cushing's syndrome should come to your mind. You know, Cushing's, the adrenal nodule was a sort of a pointer that what is happening. Because this patient has got a lot of fat. Even here, there is a lot of fat. And when there is epidural lipomatosis, what happens is it compresses the thecal sac like this. And when it compresses, it is mechanical effect and it can cause a lot of symptoms. So, so this is a potential long case. You know, the bar in 2B exam is going up and up. This case has not come in the exam. It can come in the exam. And please remember, part of my endeavor was to show you, just develop your eyes, you know, the different signals and things like that. So that is why I have selected this case. Now, another case for you. End of case 1, case 2. Pain and numbness, left leg. Over to you.
So T2 sagittal.
Okay, hint. You have to spend your time on this T2 and over to you.
Okay.
Left side. You are a bit handicapped. You don't know which is left and which is right. But I might guide you. Let me see if you pick up something. Where is the left side and where is the right? I'll tell you. So this is the right side. This is the left side. You're going into the left side now. Now concentrate. Do you see anything?
I've got a low signal in the pedicle of L4.
Where is that?
Here. Can you see me on? I don't know. Oh, I've lost control.
L4. No, okay, I'm going to show you a sequence or a where what is happening at this level.
There's a protrusion at the disc, bulging of the posterior disc, although it seems separate to the.
Where? Point out.
At level.
No, your mouse is not showing.
Oh, okay. Yeah, where your mouse is basically, just near there. Yeah, there. Yeah.
Okay, so let's go to the other sequence quickly to axial.
Okay. Should I do that? Yeah.
Yes, yes. You are having problem, then I can take.
No, it's fine. I just didn't want
Okay,
to.
go to axial. Please keep going. Yeah, keep going. Yeah.
Okay, so in the left foraminal zone, there is a disc protrusion that is causing.
Go down, please. Okay, continue and go back up now.
Okay. So I think that's separate to what we were seeing, and this is the level of the abnormality. Was that the level?
Okay, just 1 second, please. So we are down here. We can see
Yeah,
L5 level, and now we are going up, right?
Yeah. So it's the superior most, yeah.
This thing here. You see this thing?
Yes, yeah. So
What is your conclusion now?
That there is a bony exostosis at that level that represents it. It looked quite separate, or it could be a sequestrated disc, I suppose.
Sequestrated disk. Okay, fine. This is a sequestrated disk, and I will do the teaching now. So this is a classical exam case. It has come in the exam, sequestrated disk, right? So what is happening here is that if you see that now you have to develop your, how do you see a T2 sagittal? You know, when I report my MR of the lumbar spine, for me the thing sequence is this sagittal, and you have to develop your eyes on parasagittal. Go to each and every neural foramen and look at all your concept should be there. What is a neural foramen? What is a lateral recess and things like that. Unfortunately, I don't have time right now to teach you. But having said that, this you can see this nerve root. It is going out. So this is that keyhole appearance, and this nerve root then goes out. Now this is the pedicle, and the nerve root which is inferior to this level will pass below it. So that is the key. And these are exam questions, by the way. They have asked in the exam which nerve root is this, and what is this, and which nerve root is this, that kind of a thing. Now, if you go up here, look here. This is the disc, and something is sitting posterior to the vertebral body. Nothing should be sitting there posterior to the vertebral body in this location. Now, if you see, this is the level of the pedicle, and then there is something here. The sequestrated disc will usually be of a different signal than the parent disc, because that is the nucleus pulposus. So this is a sequestrated disc. Actually, even on a T1 weighted sequence, you can see something sitting there. And on an axial slice, this is sitting here. Now, this is the pedicle, and you can see the lateral recess, which is compressed. So the examiner is going to ask you which level. So if this is the L3 pedicle, it will be the L3 nerve root, which goes below this. So that's a Viva question. So this was a sequestrated disc fragment, which is here on a T1 weighted sequence, also is visible. Okay, now we go to last candidate and last maybe case of the day.
Thank you, Dr. Cohen.
Thank you very much. This is candidate 3. Are you with us?
Hi.
Okay. You are seeing the last case, and can you see this slide, case 1 spine written?
Can, yes.
Yes, please.
I can see that, yeah.
Okay, so over to you.
Thank you. So this is a 64-year-old female, left sciatica rule out disc herniation.
The same formula which I told you in the last case, look at the neural foramen, and parasagittal, look at the neural foramen, and yes, please.
Yeah, so this is a T2 weighted sequence, and as previously noted there is a lesion anterior to the, or rather posterior to the L4 vertebral body.
Does it go into the neural foramen? Here, just stop there. Next, yeah.
Which extends, I think this is to the, I'm not sure which side, I think to the left side actually.
Yes, yes, it is left.
And it just goes beyond the foramina, but not beyond it, not completely beyond it, just to the foramina itself.
Excellent, excellent. Next series, please.
Yep.
And keep going to the next series. This is a T1. Can you see it here? Go back, go back.
Yeah, you can see the fat, and there's a normal tissue.
Go back. Yeah, just stop there. Here you. Can you see it?
Yeah. So you can see the epidural fat, and this is a normal sequence.
Excellent. Next, please. What are you going to do? The Viva question will be.
I mean, I'll inform the clinical team of the sequestered disc, and I'm also going to.
Are you sure it's a sequestered disc? Can you go to the axial?
I can
Can you go to the axial?
as well. Yes. Sorry. I'll look at all the sequences available.
You see, the morphology of the previous lesion was different. This is different.
I'll open up in a second. Sorry, I think I was going the opposite direction.
Yeah. So here is the lesion, right?
Yeah. So on this T2 weighted sequence, I note that the lesion I noted on the sagittal views appears to be separate from the disc, but it appears to be in communication with a structure going through the foramen on the left.
What are you going to advise?
This could be a neural lesion.
What will you do?
I would like to give contrast to see if this enhances.
Please go to the next sequence, please. Continue. Continue.
Yeah.
Have you gone back?
So I think there's.
Excuse me. Don't stop here. Please continue.
Oh, let me just speak up. So I think the lesions again seen. This is.
Can you hear me?
Yes, I can hear you.
I don't want you to describe the sequence. Please
Okay,
go to the next series.
Okay, yeah.
And this was a pre-contrast. Please go to the next series.
Okay. So this is the next series, which is post-contrast.
Here you are.
Yeah. So the previously noted lesion enhances.
What is your conclusion?
So this is a neurogenic.
Excellent.
Neurogenic lesion. So I think it's probably a meningioma or neurofibroma.
Why do you say meningioma?
It's a neurofibroma or schwannoma actually.
Schwannoma, yeah. This is what you meant, isn't it? Because you use the word neurogenic, which is the correct word. So schwannoma or neurofibroma. Okay, fine. I'll take the mouse from you. Thank you. Well done. So if you go back, now in this particular case, the lesion is, now this is the disc, this is the disc. Look at this lesion, it starts from here and then it goes into the neural foramen. So look at the configuration and then it is in continuity with the disc and you can trace it backwards. It is also visible on this T1 weighted sequence and then on this T2 weighted sequence you can see it and it is in continuity with this nerve root, and once you give contrast then it is sort of in continuity with the nerve root, and this is in keeping with neurogenic schwannoma versus. Now on this parasagittal post contrast also you can see the same thing very well, but the examiner will expect you to pick it up on that T2 and then take it from there.